Hello, and thank you for joining us today for our Conversations with Professional series. I'm Cynthia Milburn of Epilepsy, South Central Ontario, and I am also the Vice President of an organization called Matthew's Friends Canada, and I'm going to introduce our guest speaker, Jennifer Fabe. Jennifer will be joining us today to provide an overview of medically supervised ketogenic diet therapy for epilepsy. Jennifer is a graduate of the University of Saskatchewan and has received graduate training in the area of nutritional neuroscience. Jen is now based in Ontario and a longtime practicing ketogenic registered dietitian at one of the largest tertiary pediatric centers in Canada. She has supported many endeavors throughout her career that include innovations of software development to support ketogenic diet therapy, research projects, innovative solutions to common challenges of ketogenic diet implementation, recipe development, and training of many dietitians. As well, she has been an invited speaker to many academic conferences nationally and internationally. Jennifer is dedicated to supporting the community and epilepsy organizations. She was the recipient of the Epilepsy South Central Ontario's Hope Award. She serves as the president of Matthew's Friends Canada, which is a branch of the global organization of Matthew's Friends based in the United Kingdom. She is proud to carry the mission of Matthew's Friends forward, which is to provide evidence-based information for medically supervised ketogenic diet therapy, support families and healthcare professionals with important information and education regarding this therapy. Today, Jennifer will be providing a presentation on medically supervised ketogenic diet therapy for epilepsy. I'm very pleased to welcome you today, Jennifer.
Thank you very much, Cynthia, for that introduction. And thank you to South Central Ontario for inviting me to join in your speaker series. I'm quite delighted to speak on a topic that I do every day on my frontline practice, but something that I'm quite passionate about. And I'm very eager to share some of the information to your client base and to the public out there. So what I'm going to do is I'm going to provide a presentation. It's going to be probably about a 30-minute presentation. I'm going to do it with some slides so that it keeps, you have some visuals to the dialogue that I'm going to provide you. So I'm just going to launch that at the moment. Let me just get that going. Okay, and just a quick, as I begin to start. Okay, so the ketogenic diet, the topic that I'll be talking about today is the medically supervised ketogenic diet therapy. There will be quite a few slides that I go through, but I understand this will be recorded. So if there's anything that you miss, you can always go back to the recorded presentation to take up some of that detail. The other piece is that if you have any questions, please put them out on the Facebook Live question box so that we can receive them on our end, and I'll be happy to answer those questions at the end of the presentation. So I'm going to provide an overview of the historical part of the ketogenic diet. It's always a nice place to begin. And then what is the ketogenic diet for epilepsy and how it is evolved in the treatment of epilepsy? What's its efficacy? A high overview of mechanism of action, the common side effects that we see, and what are some reliable ketogenic diet resources? So with the historical, let's go to the history of the ketogenic diet as a use of medical therapy. So many of you have encountered the great thinker, or have heard of the great thinker Hippocrates. And Hippocrates, in his sort of great philosophical pondering, had once said to us that seizures perhaps can be cured with abstinence from food and drink. And he was referring to a fasting state and perhaps that seizures could be controlled that way. He was such a forward thinker. And even if you look at other points of history, you can see somewhere along that same thinking. This is a biblical reference where you see from the chapter, Mark chapter in the New Testament, where Jesus, the famous story of where Jesus was able to rebuke a demon from a boy who was thought to be possessed, and where he foamed at the mouth, became very tonic and rigid, and thrashed around. And the disciples were unable to cure this boy, but with Jesus, he said, "I rebuke this demon," and he came out. And the disciples asked humbly, "How were you able to do it?" And it was then he said, "You cannot do this sort of task of rebuking a demon unless you fast and pray." Now, there's value to prayer for some, but certainly the scientific and medical community, along with Hippocrates, felt that there was value to something regarding fasting. And if you move forward into the 20th century and in the medical literature, you see various reports with in different parts of the world where people were observing the same thing, that people who had multiple seizures would actually start to deprive themselves involuntarily of food and put themselves in an involuntary state of fasting. And after a prolonged period of fasting, they were able to see a reduction in seizure frequency. Now, Lennox had described that the control of seizures perhaps is the change or the shift of the metabolism that goes as from a primary carbohydrate fuel source over to breaking down our body fat. And in other parts of the country and the world, there was the development of our understanding of the Krebs cycle and fatty acid metabolism. And Woodyard had realized that acetones and beta hydroxybutyrate were metabolites that appeared after we went on a starvation diet, or we ate too low of a carbohydrate-rich diet, and a diet that perhaps was high in fat. And so one of the points of reference we have in our history of ketogenic diet therapy is Dr. Wilder, who proposed that perhaps we can achieve ketones in our bloodstream, which is ketonemia, and do that not through starvation, but doing it through nutrition to mimic the starvation state. And out came the birth of the ketogenic diet, a diet that was higher in fat, adequate protein, and low in carbohydrate. And for the next couple of decades, it was used, but it had a challenge of being implemented. There were dietitians back then, and they were training their patients to become, more, prescribed in their ketogenic practice. But what was evolving concurrently to that was the anti-seizure medication era. So in 1940s onwards, there was the evolution of more medications that were available to the market, and the ketogenic diet was concurrently developing a reputation of it being too impractical mostly, and then also being unpalatable and hard to commit to. So fewer children were being put on the ketogenic diet, and fewer dietitians were being trained, and then it developed a reputation of it being an ineffective therapy. So it fell to the wayside in sort of medical approach. And then fast forward to the late 1990s, and with all the anti-seizure medications available in North America, still 30% of the population with epilepsy remain drug resistant. So the resurgence of the ketogenic diet treatment began again. And in the late 1998, a landmark study put forward by Dr. Freeman and his group put forward a prospective study of 150 children that was nicely defining that ketogenic diet when it was medically supervised by a dietitian and a physician and a team, that it could be effective in reducing seizure control. They measured time points at the 3-month mark, 6-month, and 1-year mark, and found approximately 30% of those who remained on the ketogenic diet had greater than 90% reduction. Going on to the 20th century and onwards, despite all the anti-seizure medications, we knew that there's still a population of about 30% that remained drug refractory. And so there became a public interest in exploring the ketogenic diet. It was perceived to be natural, a non-drug option. And there's the famous story of Charlie Abrams. And he's the boy behind the Charlie Foundation. It's based in the United States. And he's a boy who had drug-resistant epilepsy, had tried many anti-seizure medications and surgery, brain surgery as well, and then arrived to the ketogenic diet at Johns Hopkins and was able to achieve seizure freedom through that therapy as well. And then the father of Charlie, Jim, began the Charlie Foundation with the mission to provide information to the public about this treatment option. Similar in the United Kingdom, the story of Matthew. Matthew was a boy who has and continues to have Dravet syndrome. And during his very young years while he was a little boy, around 2 or 3, he had gone through several thousand of seizures. Emma, who's seen in this picture here, who tried to champion the care and explored all the drug options and treatment options, asked about the ketogenic diet, but was dismissed from sort of approaching it because it was like it was historically dismissed to be unpalatable, dismissed to be, impractical, etc. And eventually she circled back to that option. And when the ketogenic diet was implemented with Matthew, he again achieved, like Charlie, achieved seizure freedom. And with that knowledge and with that experience, it inspired her to begin the Matthew's Friends charity, which is based in the United Kingdom. And they have really taken over and branched out in many branches, such as in Canada, New Zealand, and other countries as well. And together, Charlie Foundation and Matthew's Friends provide evidence-based information regarding this treatment for the people. So what is the ketogenic diet? So many people, I see this all the time with my patients, they feel they know what the ketogenic diet is because we are so bombarded, especially in these days of social media, with the different definitions and different people who seem to be authorities of ketogenic diet therapy and it's very hard to filter through these wavering definitions. So I took a quick snapshot of what I see out there in social media. I see low carb diet, I see low carb, high protein, low carb, high fat, very low carbohydrate ketogenic diet, all this different nomenclature, which confuses me, but also must confuse the average citizen out there that's trying to review what exactly is the ketogenic diet. But what I want to discuss today is the medically supervised ketogenic diet for epilepsy. And it is a medically supervised diet that is high in fat, adequate in protein, low in carbohydrate, that is consistently consumed, designed to mimic the metabolic effects of starvation, used in the treatment of epilepsy and other related disorders. A metabolic diet treatment, it is a metabolic diet treatment whereby the nutritional ketosis that is created is believed to be therapeutic. What do you eat on the ketogenic diet therapy? Well, in general, the food will be of higher portion of the fatty food category. And then you'll have adequate protein food choices, and you'll have the least amount in sort of your carbohydrate food choices. There's different ways to implement it. You can have weighing of food on a scale, which is the most precise way to kind of achieve the prescription that you need for your ketogenic diet. You can also use household measures, which is practical and easy to get, and as well estimating measures, which is probably the least precise of methods. A basic meal structure, when you're starting out on the ketogenic diet, should have some sort of fat source, 1 or 2 fat sources. And I offer sort of examples of some pretty practical ones that we use to start families off. So we're talking whipping creams, margarines, maybe butters, salad dressings, nuts and nut flours. Protein sources are still the same in our regular diet and in the ketogenic diet. So your meats, your cheeses, your eggs, and your nut butters. And then your carbohydrate sources are typically fruits and veggies. Now the ketogenic world has certainly exploded in a commercial sense. And so I know there's a lot of low carb breads and low carb noodles out there. So some of that we piggyback onto and try to implement those into our ketogenic diet as well. So, low carb noodles, low carb breads. And then of course we try to have some sugar-free beverages to also support the hydration of a basic meal. As a registered dietitian, it's very key to have one on board when you are considering the ketogenic diet therapy treatment option for yourself or a loved one. The dietitian plays a central role in trying to assess the proper diet therapy for you, as well as how safely we can implement it, and also goes along the journey with you to make sure it's safely implemented. And here I just outlined some of the general duties that my colleagues, myself and my colleagues across the country and the world will do for a family that is embarking upon the ketogenic diet. Some of it will be diet history analysis, proper calorie estimation, suggesting your ketogenic diet prescriptions, and supporting the methods of which that ketogenic diet prescription will be implemented and sustained, because there are different ways, methods, and techniques that we use. And as well, we look for always the safety and making sure we're not bringing harm to the person that's implementing it. And we do a lot of teaching so that you can have independence and sustainability with this therapy. Now, what are sort of the different meal preparation methods? I have this question all the time, so I just put a section in my presentation to cover this. You can see there's a very prescriptive meal plan method where your ketogenic dietitian will initially calculate something out very precise. So for this one, this is a real life example of a cheese and spinach omelet, where you take the eggs, cream, cheddar cheese, spinach, and margarine, and make that into an omelet with some strawberries on the side and your beverage as well to drink. It's very precise. You can see it requires a scale, and we measure it to the gram. And the ingredients are very specific. So you can see I'm very brand name specific. In this example, I have the certain kind of whipping creams and the brand names that I would like, because the math is already calculated in using those brands. The cheese is also a particular brand name. So it's a bit more rigid. A dietitian helps you do swap outs if you need to do an exchange because you don't have the black diamond cheddar cheese, for example, to help you find the appropriate substitution. But that's a little bit more labor intensive. But it is very precise, and you will be given a goal of fat, protein, and carbohydrate by your dietitian or physician. Another method to use is a food exchange method. This is just a quick example. Food exchange lists allow for hundreds and hundreds of foods to be interchanged within your different categories. So you have your fat category, protein and carbohydrate category, and your list of foods, you will pick from your list of foods for each of your meals, lunch, and dinner. It allows a lot of flexibility so that the user can self-select. It can help for populations that live in different areas and have different food supply. So exchange lists are very versatile that way, and it allows for more independence from the dietitian, but also allows them to be independent in terms of a variety of food. So it's great for somebody who's a bit more selective in their eating and likes to have a lot of change in their diet. Whereas the first method I presented is geared towards children and adults who don't really have that big of a variety, and they maybe only eat 10 or 12 meals, different kinds of meals in sort of their week. And then there's sort of a method called estimating portions, where it's less labor intensive. You don't really use a scale. You might be using household measures, but you need to develop a fluency in label reading, develop a fluency in calculating out your own carbohydrates. So you have to be somewhat okay in your math and cross multiplication to be able to determine your carbohydrate count and your fat count and your protein. A lot of the labor of the diet falls back onto the actual user, and then it probably will require the dietitian to do diet histories every 3 to 6 months just to make sure that you are on track. The potential for this is that it's less precise because of the fluency and the counting that is required and the math that's required from it by the user. Practical examples of real life ketogenic meals. We have some some of our keto pizza up in the left-hand corner, some cut up waffles, some breads, some keto breads made from almond flour, some of our soups. We have a modified Atkins recipe up in the right-hand corner with the beans and the cucumbers and the meat. As well, we have, I like the cupcake example because keto families and keto birthdays can happen, and you can create cupcakes and cakes that fit in to a usual celebration, and you might not even know which one is the keto cupcake. Generally, there's no food group that is excluded in the ketogenic diet. We do reduce the carbohydrate-rich foods and do increase the fat intake, and it leads to more creative groceries. But with the guidance of a registered dietitian, it usually, the feedback from families is it takes about anywhere from 3 months, 1 month to 3 months to really get into the routine of preparing meals in the ketogenic diet way. And what if you are a person that has tube feeding? So if you are a person that requires tube feeding, we do have in Canada options for you. There are different formulas provided by different companies. I've provided what I know of the options here available in Canada. And these can be provided by gastrostomy tube or gastrostomy jejunostomy tube, GJ tube for short. And if you are more leaning towards the blenderized tube feeding, that can also be implemented. I have a few patients on blenderized tube feed that we implement by a syringe G-tube, and that is also an option to you. But this needs some support from your registered dietitian and medical team to make sure it's operationalized, that you get your coverage for your products, and that you are implementing it safely. And some of you may have a combination of oral eating and tube feeding, and certainly that is a possibility too, that we can do a mix of the different methods that I just presented, that you can orally and tube feed the ketogenic diet. But again, you need the help of a team to do that. This is the next slide of it's busy, but I just wanted to be thorough, that there is different types of diets out there. And this is not for you to decide upon yourself, but just to inform you that there are different sort of methodologies out there. There's the classic and the MCT ketogenic diet, the modified Atkins, and the low glycemic index. The overview of this is that they do differ in the percent macronutrient distribution. So the percentage calories coming from fat will differ from these three different methods, as well as protein and as well as carbohydrate. It will be a discussion with your team as to what would be the best fit for your situation, your nutritional state, what you're capable of doing, your type of epilepsy, etc. So that's just to inform you of the different options. Now, the evolution of ketogenic diet therapy. So there's been many different sort of diets that have evolved over time. We have, like I said, the classic version, the MCT ketogenic diet, the modified version of the ketogenic diet done in the United Kingdom, the modified Atkins, the low glycemic index. But each will differ in their approach of their variance in percent calorie distribution of macronutrients. These approaches will differ in the pace of how it's initiated, whether it's done as an inpatient or whether it's done as an outpatient. They will be different side effect profiles to these methods. They will have different efficacies on seizure control and different compliance statistics. And again, this is just to reiterate in a visual sense that there are different macronutrient and macronutrient distribution. By that I mean the percentage of your food coming from fat, the percentage of food coming from protein, and percent of your food coming from carbohydrate. And depending on the type of diet you're using will show a different sort of shift of what macronutrient profile you might be adapting. So the classic version of ketogenic diet, sort of a typical percent calories from fat would be 87% of your calories coming from fat. Very significant when your typical diet, if you come to see me, it's probably ranging in the 30% range. So maybe 40% if you're sort of trying to go the higher fat route, but it's a pretty big jump, over double of the amount of fat that you're eating now. The MCT diet allows for the use of a medium chain triglyceride oil that you would obtain through your team, and it allows for a little bit more liberal carbohydrate inclusion. You can see the classic version has 5% carb, whereas the MCT has about 15%, and MCT is a big chunk of your percentage of fats. Modified Atkins and low glycemic index are another sort of methods of implementing the diet. They have about a 60% calorie distribution coming from fat. They vary on their carbohydrates, and they use exchange lists at times and protein. But again, those are options you can discuss with your team when you're considering this as a treatment option. So when you're considering initiating, there's variables that you need to consider. Do you initiate the diet as an outpatient or inpatient? Should you slowly titrate or rapidly titrate? Do you hydrate restrict or not hydrate restrict? Do you fast before you start? Do you not fast before you start? And how are you going to titrate the diet? What is the language that you're going to use? I go back to the busy slide and I show that again, to remind you, there are all these different options of ketogenic diet. I included sort of the method we use at my work at McMaster Children's Hospital, but all these options sort of are encompassed in practice, and you can implement this and in the discussion that from the former slide that I had as to how you're going to implement it. The efficacy. So how efficacious is the medically supervised ketogenic diet therapy in epilepsy? So this slide has not changed in my entire 19 years of practice. And I refer back to the consensus statement of recent and I see that the ketogenic diet is still considered to be a second-line treatment after anti-seizure medications are considered to be not as effective in supporting seizure control. So after you've tried the second anti-seizure medication and you're working on your third or fourth, there is a possibility that your team might consider proposing to you the ketogenic diet therapy. You might concurrently be starting another medication, but that discussion might begin, and that's sort of the where it still sits in terms of practice. Other options along the same lines of ketogenic diet therapy, you might be also concurrently being worked up for surgery or VNS as well. In terms of efficacy, though, we look at the literature and the evidence, and in the 2018 Cochrane review, you see that it included 11 randomized controlled trials. And when you looked at the adolescents, you saw that about 55% of those on the classic ketogenic diet of ratio 4:1 at the 3-month mark had achieved seizure freedom. And 85% of those on the classic version of the ketogenic diet, that's the most strict version of the diet, the most restrictive, achieved an 85% reduction. Whereas in the modified Atkins group, you achieved only 25% in the group of 66 adults achieved seizure freedom, whereas seizure reduction was achieved in about 60% in the adolescents. In the adult group, sadly, there was not a seizure freedom achieved, but what was nice to report was that there was 35% seizure reduction. And what about the adults again? So in Yi and his group in 2015, they looked at the classical ketogenic diet and the modified Atkins diet. And what you see here is that in the compliance, it sort of was a reverse. So the classic ketogenic diet had less of a compliance at 38%, and modified Atkins, because of its more liberal nature to it, had a compliance of about 56%. And for those that discontinued, the major reason for discontinuation was lack of efficacy. Now, what about the infants? So infants who have infantile spasms, as an example, were compared by the COSOF group, and in a retrospective chart review, they compared traditional treatment of ACTH with ketogenic diet. And you see, with this small study, they saw over 50% of their patients that were placed on ketogenic diet achieved spasm freedom, compared to those that were using the traditional approach, who still achieved very high, almost 90% achieved seizure control with the ACTH. So it does show that you can use the ketogenic diet for infantile spasms. Perhaps there's less side effects, and perhaps you relapse less. But again, it's a small study, but encouraging results as a possible treatment option. The Hong group in Asia in 2010 suggested that when they started ketogenic diet in those that had already tried at least 3 anti-seizure medications, when ketogenic diet was implemented and evaluated at 6 months, over 64% of those patients achieved greater than 50% spasm improvement. And that continued on to be about 77% after 1 to 2 years. And in 2013, another group showed that 17 children who had resistant infantile spasms to traditional treatment of vigabatrin and hydrocortisone achieved spasm freedom in about 76% of those that attempted. So encouraging results. I just wanted to present sort of the age spectrum that it can be applied to infants all the way up into the adult world, adolescence and adult world, and to say that there's encouraging efficacy results between all these age groups. There is a consensus statement that I included in this presentation as a quick reference, because to reiterate to the public that many experts across the world come together to convey an agreement of how we should optimally manage the ketogenic diet therapy for epilepsy, and to guide the practitioner to make sure that we're optimizing it the best we can based on the current evidence, but also to caution the practitioner in terms of safe practice and also contraindications of the ketogenic diet. And here, I'm not going to read the article to you, but just to itemize some highlights. So there in the article, it does identify syndromes and conditions which can benefit the ketogenic diet therapy. You refer to table 1 and 2. But table 3, it does identify where the ketogenic diet is contraindicated. And so many feel that the ketogenic diet therapy is without harm. It's a belief that it's a natural therapy. How could it create any harm to the person because it's done with nutrition and food? But that is an incorrect sort of thinking to have. When you don't perform the proper screening prior to starting the ketogenic diet, there could be significant harm that can happen if you start the ketogenic diet. I blow that table up a bit more for this next slide, and you see that there's these inborn errors of metabolism, these syndromes that exist that just require some simple testing by the ketogenic diet team to make sure that you are not incompatible with the ketogenic diet therapy. If you were to begin the ketogenic diet therapy and you have some version of these inborn errors of metabolism, this could result in a major metabolic crisis and a deterioration. So we caution very carefully that it is never without harm. It's not something to be tried without the proper screening and evaluation by your team. What is the mechanism of the ketogenic diet therapy? Always a common question. I only have a couple of slides regarding that. But going back to our great thinker Hippocrates, the father of medicine, he had said to us, "Let food be thy medicine, and let thy medicine be thy food." And you think, fast forwarding now to the present day, boy, was he correct. There is something magical that happens when we do consume ketogenic diet therapy, to achieve a therapeutic ketosis. We are able to generate and use those ketones for the benefit of us in different stages of our life. In our sense, it's for the ketogenic diet for epilepsy, but even in our most natural state during infancy, without seizures and without ketogenic diet, we use our ketones. It's one of the first fuels we use when we come into this world. And so we use that as a fuel for our infant brain until we're able to take up carbohydrates better. And as well, in adults, we sometimes will use ketones as a backup fuel when we are in a sort of a ischemic state or a trauma state or in a low glucose state. It's sort of our backup fuel. So it's a very beautiful biochemistry concert that we have between our carbohydrates and our ketones. And the ketones we produce not only from our body, but through our food are 3 different types. And they're fancy little chemicals that I have on the left, but they are the chemicals that we measure in our breath or even in our blood and our urine. And these ketones that we measure are actually ketones that actually get absorbed through the cells and actually uptake into the brain, and thought in part that it helps support in our seizure control. And here I provide a different overview of mechanisms of how the ketogenic diet might actually work in terms of supporting seizure control. There's direct and indirect mechanisms. This is not the time for that discussion, but I just wanted to present to you that it is a very multifaceted mechanism. And this very simple diagram tells you that there's a sort of a concert of patterns that go on between elevated free fatty acids and a reduction in glucose. Now, the side effects. The common side effects of ketogenic diet are that you can increase the hyperlipidemia or high cholesterol. So what we have seen in some of the literature is that you have increased triglycerides and total LDL, which is sort of our lousy cholesterol, in some of our children who are on the classic ketogenic diet. This is observed perhaps in the first month of therapy that your body's adapting, but can preliminarily, the data suggests that there is a transient and serum lipids this is transient and serum lipids will normalize within the first year of therapy. And I do see that sort of in our practice. I don't believe that hyperlipidemia is a major issue for us. Coronary artery disease. The risk of coronary artery disease is sort of a long-standing sort of question for us, and what the evidence has suggested in the longitudinal studies that we do have and the evidence that we have right now, in the pediatric world, we are not seeing a thickening of the carotid intima, which is one of our arteries within our neck, to see if we're actually thickening our arteries when we compare it over a 12-month treatment. Local and systemic arterial stiffening will increase in some studies involving children and young adults, perhaps who have elevated triglyceride and cholesterol. So something perhaps to monitor. We have also cardiac abnormalities that are potential risks. So we have children on ketogenic diet that have been reported in literature to have cardiomyopathies or prolonged QT intervals. It's associative. We're not sure what the mechanism of that is. Sometimes it is associated with selenium deficiency, but sometimes we have seen these observations in the absence of selenium deficiency. So supplementation is important to make sure that a ketogenic diet is not creating a risk for cardiac abnormalities. Renal calculi is a fancy word for renal stones or kidney stones. And the risk is fairly low. About 3 to 7% of children will sort of experience that, the renal calculi side effect. But it can be supported using oral citrates and change the acidity of the urine, so to decrease the chance of its formation. Growth. Unclear if the ketogenic diet therapy can affect long-term growth. We still just need the longitudinal data for that. But we do, as dietitians, for pediatrics anyways, try to support our children to optimize their growth as best they can. We also see, we monitor our growth longitudinally as well through our phone follow-up. So you'll often hear us asking for weights and heights. As well, you might see reports of decreased hunger or appetite. There's an appetite suppressing effect sometimes with ketogenic diet, perhaps some acidosis with the ketone acids that are being created, but you can easily buffer that with some hydration. Low sugars called hypoglycemia, transient irritability at times, sometimes drowsiness, sometimes lack of energy. A common one is constipation. And that's typically because of people not drinking enough water or not having enough bulk in their diet because we're now lower in carbohydrate. So constipation is a common side effect with that we see on the front, clinical front. And then you'll also see vomiting, diarrhea, or hair thinning, which again is managed. It can be very transient, but it can be provoked sometimes if we're inducing too quickly or during times of illness. The hair thinning could be nutritionally induced, so that's why, again, it's important to have a team on board to make sure you're having adequate protein and enough supplements to put your risk low of for hair thinning and alopecia. And some have reported that you might have a bit of reflux with ketogenic diet, which makes sense in that you might have delayed stomach emptying with the higher fat diets, and so you may have some reflux-like behaviors and have a bit of heartburn. The diet is not, again, benign. It does not marry well with some medications, or you have to approach with caution with medications such as valproic acid, topiramate, some lipid-lowering medications, and some diabetes medications. And in common practice, you will see us see the side effects of vitamin mineral deficiencies that you will see here, anthropometrics, again, looking for weight, height, and growth, acidosis, bone density, and prolonged QT intervals. All of those things are sort of our common side effects surveillance in practice. So I just wanted to share what we see on the practical front. In comprehensiveness, we actually will supplement every ketogenic patient, typically with some sort of multivitamin, perhaps a calcium and vitamin D, depending on the type of diet they're on, some magnesium and phosphorus, also all to protect bone health. And then electrolytes, iron, zinc, and selenium. Those are some very common supplements. So the diet, in addition to supplements, sort of rounds out the nutrition completeness. And again, surveillance according to consensus statement and best practice is to do your routine blood work. And taken from that consensus statement, I kind of share what we've done here at McMaster, and we do a lot of blood work that happens before ketogenic start and as well every 6 months, just to make sure that there's no side effects, and if there are some deficiencies that we correct them at the time of they're identified. We look at liver function, we'll look at cholesterol, we'll look at pancreatic function as well, and overall acidosis. We'll measure ECGs every 6 months, growth, diet history, abdominal ultrasounds if needed, and bone density if needed, again, with the recommendation of your team. And at home, it's not just the team that's going to monitor, but we do expect our parent and caregiver or the patient to do some self-monitoring as well. So at home, it might not be uncommon for your team to ask to measure blood sugar and ketones or urine ketones at home. You might be asked about your bowel movement regularity because, as you recalled, I mentioned constipation is one of the common side effects we have. And of course, we'll be asking about seizure frequency, duration, and recovery. So when considering the ketogenic diet, there's many things you should consider. How your family will adapt to this. What are your community resources? Do you have a ketogenic diet team, and are there hospital resources nearby? When you're initiating the diet, you should consider all these variables I outlined in the screen with your team of how you're going to approach the onboarding of your new diet therapy into your lifestyle. And if you're going to titrate, use different language. And often I would be incomplete if I didn't describe the traditional way of describing ketogenic diet. And it's often described in ketogenic ratio. And ratio is described as 3 to 1, 4 to 1, sometimes 4.5 to 1. And all it means is the first number, meaning the grams of fat in relation to the sum of the grams of protein and carbohydrate. And it's a way of describing your ketogenic diet prescription. It's a very traditional way of describing it. There's advantages and disadvantages of describing it in the ratio method. I use many methods to describe my diet therapies, but this is one of them, and you'll see that in our language as you begin your conversations. And you can see titrations can be in different ratios, starting at 1 to 1 and going up by 0.5s in a stepwise fashion. Another way to titrate is using percentage calories from macronutrients. It's just another way to use the language to describe how you're going to titrate your ketogenic diet on board. And then finally, you can implement the diet by just having your team say, well, you're going to just have a carbohydrate goal, and then you're just going to encourage the fat or the protein. This is done in the modified Atkins diet and the low glycemic index diet. They also set a carbohydrate goal and then encourage the fat intake, and some meal plans are also supported as well. So again, coming back, it's not something to take lightly. You should consider all the supports that you require to make it successful so that you onboard successfully and maintain the ketogenic diet successfully. So you have your best chance at seeing if the ketogenic diet is a reasonable treatment option and a sustainable treatment option for you. I'm just going to keep fast forwarding. And if you are looking for any community resources, please consider looking at the MatthewsFriends.org website. Coming soon will be the MatthewsFriendsCanada.org website. There's, if you're in the United States, the CharlieFoundation.org website, as well as the Spark sheet that's available from your epilepsy organizations in Ontario. Dietitians of Canada, for the health professionals out there, have PEN approved. So that stands for Practice in Evidence-Based Nutrition. They have approved our Matthews Friends Canada tools. We have about 10 of them out there. I've posted about 8 of them here that we use to support our healthcare professionals in terms of providing evidence-based information to their patients. And as well, we have our YouTube channel. Matthew's Friends has a global newsletter sharing updates of our activities as they come about. So sign up for those. And technology will always be a part of sort of the evolution of our lives. Welcome to Zoom and all the sort of our web-based talks that we have now. But technology will be emerging in the ketogenic world. So ask your team about ketogenic diet calculators and keto suite calculators, etc., because they will help make your diet implementation a lot quicker and easier. So The overview for me is that the ketogenic diet is a complex therapy. When implemented as a therapy, it is rigorous. It has variations, but they're marginal. It allows you to achieve goal ketone production, and it has its therapeutic effect if you continue to have a steady state of ketone bodies. It requires shifts in macronutrients, and it is associated with adverse side effects, so be cautious. It should be implemented as a medical therapy, and always screen for the inborn errors of metabolism to make sure that you don't put yourself in a possibility of severe metabolic deterioration. The ketogenic diet therapy, when used in lifestyle, is less defined in terms of how macronutrients are shifted, so be cautious. Be cautious about what you see out there in social media. Be cautious about what you pick up in terms of making significant claims, because the evidence really has lied in its bulk in the epilepsy world. A lot of evidence has to evolve still for the other applications of the ketogenic diet. So it's caution, be cautious, and buyer beware with that. And as well, if you have any further questions, please put them in the Facebook chat. And if you have any questions that you want to send to me privately, you can just send that through our website as well. Thank you guys for enduring that presentation. I know it was a little bit long, but I hope that it was informative enough for your client base.
Thanks very much, Jennifer. A lot of information, a lot of very valuable information, and a reminder that this presentation has been recorded, is being recorded, so it will be available afterwards. So if you want to go back and look at the video either on Facebook or on YouTube, and then you can stop it and look at the slides and review, because it's a lot to take in all at once. You know, the keto diet is procedure control, and it is an actual prescription and medically supervised, and it provides hope when a person is drug resistant. So we have a few questions coming through for you. Well, here's one. Can I start the ketogenic diet therapy on my own?
So hopefully through the presentation, I've emphasized that no, that you shouldn't be starting your ketogenic diet on your own. For many reasons, the contraindication table of our consensus statement is number one. You may have a mild version of an inborn error of metabolism or something that may contradict you using the diet itself. That aside, you might have other conditions that might worsen if you start the ketogenic diet therapy. So it's probably important best to have a discussion with your medical team when you're considering this treatment option to support your epilepsy.
And how, Jen, how long would someone be on the ketogenic diet therapy?
Yeah, I get asked that question a lot. So some people who are on the ketogenic diet therapy, the consensus statement suggests that maybe 2 years and then consider weaning the ketogenic diet. But for some, it's for as long as it works. Some have different philosophies. And so it's a bit of a discussion. So, and it's lifestyle based too. So if it's been an effective therapy and you're considering wanting to wean, don't wean on your own. Consider doing a graduated titration downwards with your team so that they're involved in that sort of management so that you're safely removed from the diet. But you shouldn't be trying to titrate it down on your own. But typically we try it at 2 years, but sometimes it's used for as long as it works. I have some patients that have been on it with me for over 20 years, but we monitor side effects longitudinally.
Good. You know, with the COVID-19, there's been some discussion. Is it harder to do the diet at this particular time? My colleague, Diane from Durham, has asked on behalf of a couple of clients, during something like this, like the pandemic, is it safe to begin a new medically supervised keto diet therapy? And are there specific specialists they should see outside of their neurologist to help with this process?
in the pandemic world. So the first part of that question is the practical things I've been seeing as I monitor Canada's situation is our food supply chain is somewhat altered with the ketogenic diet. So from a practical sense, you're seeing small changes with food supply availability. I haven't heard major changes, but and also grocery shopping becomes a practical sort of endeavor for every family because it's much slower to actually do your groceries now. So preparing your lists to do your groceries is probably prudent because you can't just whip to the grocery store to pick up some item that you may have forgotten. So those are sort of the practical feedbacks that I'm getting from the families, and sometimes, you know, restocking the shelves is a bit slower. So so that certainly is a practical situation that has evolved from the COVID-19 situation. The other piece to it is in terms of COVID itself, I don't feel that there's a contraindication, and neither does the evidence suggest it. You need to be carefully monitored with your epileptologist or neurologist to do so. If you're experiencing some of the diarrhea that may be associated with COVID sometimes, then maybe you have to consider having that discussion because it might not be the right time to start the ketogenic diet. But you can start the ketogenic diet as an outpatient. And so that can be done, just depends on the capabilities and sort of what your team is capable of doing. Can they support an outpatient initiation, and can they follow you through modalities like you know, video calling and telecommunication tools to make sure that you're safe. So I don't think it's a negative. No, I don't think you cannot start, but I think you need to just talk to your team to see what they're capable of doing.
And the diet, it provides hope for people, but you know, there are side effects, which you did touch on. Mm-hmm. So so you did touch on the side effects in the question, there's other side effects, but as well, knowledge is power. So to know what could possibly happen is always a good thing. But yes. Are these side effects prevalent in all patients, or is it rare, or what's your
that's a good question, because those slides, it was comprehensive because I wanted to inform, but I'm not trying to scare. The common one that I kind of see with most families is the constipation, for sure, is number one. Your bowel movements are going to become less regular because there's just less fiber in the diet that you're eating. You have to have mobility. You should try to have hydration. The vitamin mineral deficiencies are real. It doesn't matter what version of the ketogenic diet you could possibly be implementing, there is risk of vitamin mineral deficiencies. And so you need a diet history analysis to be done so you have the proper vitamin mineral protocol. So those are the two common ones I would see. And a lot of institutions will do the ECG, the heart monitoring, just as proactive surveillance. But I don't feel that we're going to be finding, like we find, you know, small abnormalities here and there. But I would say the common ones would be, certainly the vitamin mineral deficiencies, the constipation. And if you're implementing the ketogenic diet very quickly, you might get a very transient nausea, vomiting effect, but that usually adapts after 3 or 4 weeks if you're pretty committed. Mm-hmm.
Question here, do you advise, I'm hoping I pronounced this right, legume-berry foods or other types of special protein foods for the keto during the classic ketogenic diet?
Okay, so like protein-rich foods?
That's what the question is just asking. Yeah, so special protein foods.
Yeah, so protein adequacy is very important in the ketogenic diet. So we don't try to achieve low protein in the ketogenic diet at all. We always try to achieve adequate protein. Sometimes in the modified Atkins, it's encouraged to go a little bit higher but not too high, because you want to avoid a glucose or a sugar generating effect of high protein. So we will implement, sort of adequate protein, and that's a dietitian and the physician assessment of how much protein you should have. But in terms of specialty proteins, we'll look at protein quality. So as a dietitian, I will always look at protein quality foods that have good bioavailability, in our food supply chain. So I don't try to recommend sort of specialty protein sources as much as possible because I'm careful about the money that these families are spending. But I certainly will entertain any products that families provide me to see if it can fit into the diet if they're really wanting to include it. Sure.
Okay, just 2 more questions. Is it right to control ketonemia 3 times a day, or is that too much?
Is it to measure it? To measure it?
It's just to control it, so you can.
Yeah. So with ketogenic diet therapy that's medically supervised for epilepsy, you want a constant state of ketonemia. So a constant state of ketones being in your bloodstream. If the question is, if you're experiencing the side effects of super high ketones and you're feeling very lethargic and nauseated, then I would suggest you talk to your team for a possible remedy to those symptoms. But if it's just to lift yourself out of ketosis during the diet therapy, you shouldn't be trying to lift yourself out of ketonemia. You should try to have a consistent state of blood ketones at all times.
Okay, and last question, what can Matthew's Friends do for an epilepsy agency in Canada?
So Matthew's Friends Canada is on a mission to try to connect with many epilepsy organizations, all epilepsy organizations across Canada, to provide them with the evidence-based information regarding this therapy and provide sort of the Canadianized versions of practical tools that we've developed to your agency and provide even the practical meal preparation or recipe development that is practical for your local areas because the foods are different across the countries. And so we want to see what the boundaries are in terms of operationalizing the diet and seeing what we can do to support that for you. But we start with information. So it's to create the relationships across the country with our epilepsy organizations and provide information, whether it be in person, if you want us to be there in person, or through the virtue of this beautiful technology that we're all adapting during pandemic world, we're able to do that as well. You just need to give us a call and we can start to begin the discussions of how best to support your agency.
That's just great, Jennifer. It's been great to have you. I enjoy working on Matthew's Friends Canada with you. We've gone abroad to the Keto College in the UK. It's a global diet. There's professionals around the world, and it's phenomenal. And so I really appreciate the time that you've taken to speak to everyone. And it is recorded, so it can be watched over and over. And we will be getting a new website shortly, matthewsfriendscanada.org. And then all of the information, diet, recipes, everything will be relevant to Canada. And I'd like to just say on Monday, we have our next series, and we have Dr. Valiente, who's a neurosurgeon, and he's going to talk about all kinds of possibilities with surgery options. And that is at 11 o'clock in the morning on May 11th, Monday. So we look forward to everyone joining us again for a conversation with Dr. Valiente. So thank you so much for joining us, everyone.
Thank you, everybody.